Hello everyone, so we'll finish up our discussion on the evaluation of patients that present to you in the clinics that you might consider to have some form of a mental disorder, and how as medical doctors it is useful for us to start evaluating first and look at their physical symptoms and evaluate and assess whether these physical symptoms have specific the diseases that could explain them, or they might be actual manifestation of mental disorders, or they might actually be some form of red flags where these physical symptoms does not appear to have any explanation or scientific upon exhaustive scientific investigation. This appears that this physical symptom does not have any explanation. Then we are able to classify them now as medically unexplained symptoms, and they are an important marker for us as clinicians when we are evaluating mental disorders. So as we wrap up our discussion on and approaches to evaluating patients with different clinical presentations, it is important to revisit some of our working assumptions and our definitions. First is that when we talk about mental disorder, you're talking about either a mental disorder, organic mental disorder, or substance use disorder. So alcohol abuse or prohibited drugs. This might fall under the category of this mental disorder based on our definition. And when you talk about disease, um, this is a more specific form of disorder, because this one, when we talk about disease, we know that it has a pathophysiologic explanation. There's an organic cause that can be explained by current understanding of diseases. And these are disorders that are included in the modern classification of diseases. For instance, the standard editions of the International Classification of Diseases, ICD-10, which is used to classify or code different diagnoses in the clinics. And in fact, they're very important when we are trying to look at health financing, because we need to uh, utilize resources for the treatment and management of diseases, and there should be a common standard for understanding what diseases constitute this particular disorder. Also, when you talk about medically unexplained symptoms, you are looking at physical symptoms with little or no disease, or there's a lack of pathophysiologic explanation. So um, before, medical scientists would refer to this disorder as a form of somatization. So when I was in med school, this was a very popular term, the somatization, which is like the physical manifestation of certain conditions uh, that might not be necessarily be physical in nature. Or right now, they are called your somatoform disorders. And this classification actually appears in the standard diagnostic manual of uh, your mental health professionals. So, for example, the DSM-4 and DSM-5 includes uh, certain definitions that covers medically unexplained symptoms. For instance, in DSM-4, they define the following MUS disorders as belonging to the somatoform category. So this include somatization disorder. You have your undifferentiated somatoform disorder. You have your conversion disorder, pain disorders, hypochondriasis, body dysmorphic disorder, and your somatoform disorder not otherwise specified. So I think some of these terms might be familiar because DSM-4 has been there for the past few years already. It is, in fact, being uh, replaced by the more current DSM-5, which I think was released around 2014, around 2014, 2015. So just a few years ago also. So for the DSM-5 category, this DSM-4 disorders were now combined into what is now called somatic symptom disorders. So they have simplified the classification of these medically unexplained symptoms into somatic symptom disorder. And hopefully when we go into the details of the specific clinical conditions that we'll be encountering in the clinics, we'll be able to discuss this more fully. The medical names for your MUS syndromes might include chronic pain, either of the low back or the neck or the head, or you will be uh, looking at fibromyalgia, irritable bowel syndrome, non-ulcer dyspepsia, or you have your fatigue syndrome. So these are unexplained medical conditions that presents in the clinic with no clear pathophysiologic explanation. So no matter how many times the medical doctors and the other health workers evaluate these conditions in the clinic, they would not be able to find any physical explanation for these symptoms. So that is why when you talk about you medically unexplained symptoms, most of these symptoms that patients have will be chronic in nature. They will have been there for quite a long time already and have been bothering the patient. And doctors will see the patient more than once. And in fact, they will be recurrent consults. And suffice to say is that according to data, your medical unexplained symptom actually, the chronic nature, the chronic one, is not rare. They are prevalent among clinical populations. In fact, about 10%, no? Recent estimates put this figure that 1 out of 10 clinic patients have chronic medical unexplained symptoms. So this is not a rare condition. So these are common complaints that patients might present to the doctor that they're consulting. So if you look at their physical symptom profile, usually when patients present at the clinics, symptoms are usually ill-defined. So I'm sure when you were doing your um, rotations now in your RHUs or in your barangay health stations, you might have encountered patients that have multiple complaints and sometimes vague complaints. So these are common encounters in the clinics. So they are ill-defined, and but usually they are related to your musculoskeletal. So maybe joint pains or back pains, or pain in the head. You could have gastrointestinal symptoms because of diarrhea. You have irritable bowel syndrome, unexplained gastrointestinal symptoms. You could also have cardiopulmonary like chest pain, which is not explained by any ECG or any workup of the patient. You could also have problems involving the nervous system like tremors or pain that is breaking in nature and unexplained by any physical examination. So pain is often prominent in these patients, and they can occur anywhere, but the usual localization of this pain will be in the low back area, could be in the neck, could be in the head, even in the pelvis, chest, and even the joints. So when you look at these physical symptoms, there could also be non-pain symptoms or complaints, So aside from pain, patients might complain about fatigue, constipation, diarrhea, or bloating. So they might be bothered by these non-painful symptoms, but these are conditions that would prompt them to seek consult. However, if you have symptoms of organic diseases such as fever, sciatica, angina, or weight loss, these are not the usual profile of patients with chronic NUS. So usually patients with chronic NUS will not tell you, or they will not come to you with complaints of fever or angina or weight loss. They would come with the other symptoms that we have just discussed earlier. Also, when you look at the psychological symptom profile, usually patients with chronic NUS will present and typically talk about uh, conditions that will be indicative of depression or anxiety uh, in their daily life. And when you meet patients with this kind of psychological symptoms, insomnia, anxiety, uh, depression, or um, inappropriate phobias or fears, or this could be an evidence of an underlying mental disorder. So you need to work up the patient, need to investigate the patient further for medical disorders or for mental disorders. So therefore, in summary, when you're talking about medically unexplained symptoms, you will have a wide variety of symptoms, but usually involve your musculoskeletal, your GI, cardiopulmonary, or your nervous systems. And headaches, you could have low back pain, you could have muscle pain, you could have joint pain, which usually does not fit any standard syndrome or disease pattern. And importantly to note is that these symptoms are long-term, they are chronic, they are multiple, and they are debilitating to the patient. They are disabling to the patient. However, take note also that while it could be worsened by presence of stressful conditions, stress is not the one that precipitates this. So this is not precipitated by stress, but these symptoms can actually be worsened by stress. Now, some patients with some prior disease or recognizable uh, pathology, for example, like hypertension or diabetes or cancer even, will subsequently develop symptoms as MUS. For example, chest pain, post-myocardial infarct. However, when you investigate patient, there is no further evidence of damage to the heart. You could also have a high likelihood of history of child abuse uh, in patients, as high as 70%, no, for patients with chronic anemia. So this points to some personal history of trauma that contributes or that is part of the profile of your chronic MUS patient. Also, patients that present to you with MUS will usually have a very high uh, health-seeking behavior. They will usually have a high number of visits that is proportional to the severity and disability of your underlying mental disorder. Usually, healthcare seeking behaviors driven by anxiety. So, we could do a diagnostic workup. This will include uh, a panel of investigation to rule out possible underlying medical conditions. And you're justified in doing that to run those tests. Or it could be a little bit expensive because you cannot really specify which particular disease you're looking at. You can do that, however, it is not really useful for patients who are presenting only with chronic low back pain. And also take note that once you have ruled out certain organic diseases by the test that you have done, it's no longer useful really to run repeat workups because according to literature, usually repeat workups does not really reveal any more significant medical findings aside from the ones that you have already discovered or did not discover in your first series of workups. So do not repeat the medical diagnostic workup anymore, especially if you are looking at a chronic MUS patient, because they do not really benefit from more workups. So your differential diagnosis can be any type of disease. You also need to consider some mental disorders that are sometimes confused as MUS, and this will include factitious disorder or self-induced disease, no? Or you could have the extreme mental disorder, for example, your Munchausen syndrome, and we will talk about this later when we go to the specific clinical categories of your mental disorders. You could also have malingering behavior, which where people have deliberately faked their symptoms to gain something from others, or to gain financially. So you should also be watchful for those kind of conditions. So mental disorders could be present in up to 100% of chronic medically unexplained symptom patients, and they are more likely uh, to be actually present when there are greater number and duration of MDR symptoms. The greater their severity and disability of their symptoms, the greater the possibility that they are suffering from a mental disorder condition. So many of the patients will present with actually will have depression, clinical depression, will have anxiety, and they might even have some prescription substance misuse, especially those who are being prescribed opioid drugs. Now, one of the things that we can actually do is to do a screening for patients that we see in the clinics, and a suggested tool that we can use is the Patient Health Questionnaire 15 or PHQ 15. It's a 15-item questionnaire that will allow us to uh, have a clear understanding of what is happening to our patients. So the purpose of that is to simply understand and evaluate whether or not the patient is suffering from any form of mental disorder. So when we ran our diagnostics after our screening, we wanted to rule out other diseases that can explain the symptoms. Most of these patients that we see presenting to us in the clinic will require careful, focused investigation, and in fact, we might refer them for a specialty consult relative to their particular symptom presentation. However, as I mentioned earlier, repeat studies are not really needed. Once you already have done the initial workup, you don't need to repeat them. And if they are normal or they are not found to be any they are not found to be explanatory, of what is happening to the patient. So what we need to do is to have a careful history, do a careful physical examination so that we could check for the presence of complicating disease. On the other hand, low-risk patients with chronic low back pain do not require imaging or other investigation. However, when you have high-risk patients like older patients or patients presenting with neurologic deficits or history of fever or associated systemic illness, then we should definitely do careful investigation. So this is what I had mentioned earlier, a screening tool that we can use in the clinic. This is your Patient Health Questionnaire, PHQ 15, which is a well-validated screening tool. And this is useful in a medical setting for identifying patients that will be presenting with medically unexplained symptoms. And in my own research, I actually use the Patient Health Questionnaire 9. This is a shorter version of the PHQ-15, which focuses on depression and generalized anxiety disorder, especially on GAD-7. So Patient Health Questionnaire 9 is a questionnaire that looks at depression, while the generalized anxiety disorder questionnaire 7 or GAD-7 is a 7-item questionnaire that screens for anxiety disorders. And in my own personal research, I have used both PHQ-9 and GAD-7 to screen for mental disorder among community-based, community-dwelling adults, no? Especially in post-disaster settings. And this is a shorter version of the PHQ-15, and they can help us understand and look out for symptoms of depression, clinical depression, and symptoms of anxiety among community-dwelling adults. Now, before we go to the specific mental disorders, which this course is all about, let me just go back to our own approaches, not to managing mental health burden in the country. We need to have what we call a mental health care model that will be our overarching approach for the treatment of mental disorders, because sometimes when you just dive into the specific clinical disorders, it's so wide-ranging, and it's so difficult to grasp and understand how useful they are, and how they can actually be used for your practice when you go to your own go back to your own community, because that is your concern. You want to be really be able to help patients in your own local community, especially those that have undetected or unmanaged or untreated or undiagnosed mental health problems. So this model is somehow the overarching framework, which is very useful, which will be useful for us in terms of managing mental health problems of our communities. So this identifies aspects of management and treatment that are common across all mental disorders. So whether it's depression, whether it's anxiety, whether it's traumatic stress disorder, whether it's phobia, whether it's suicidal thoughts, this can be a useful roadmap for us as a way of organizing our approach, no, to the treatment of patients or helping patients deal with their mental health problems. So there are 5 key dimensions that are important in this model. For mental health disorders, first, it is important to emphasize that we need to establish communication and an effective clinician-patient relationship. So, in my own experience, no, both in the general clinics, in clinical medicine, and also in psychiatry, and even in the larger social scientific discipline of psychology, they have compared those clinicians that have been effective in managing the condition of the patient. And what they have found out is across a whole range of specialties, what is common among clinicians that are effective in managing the condition of the patient is that they have been able to establish an effective relationship with the patient. So number one, it's not even your skills as a clinician. It's not even your, your training as a clinician. It's first and foremost your ability to be able to connect, no, with a fellow human being, those who are suffering from certain physical or mental problems, mental health problems. So number one in this framework is the emphasis on communication and developing an effective clinician-patient relationship. There should be a trust-building mechanism that allows patients to develop a closer working relationship with your doctors or your nurses or other healthcare professionals. So that's number one. Number two is that there's a need to look at the patient as somebody who can understand what is happening. So there's a need to educate the patient. This will require some resources. This will require patience also for the clinician, and time also, because this will be important in making the patient as a partner treatment. So first and foremost is share knowledge and skills to the patient to be able to manage his or her condition. Third is we should obtain the patient's commitment to the management and treatment of his condition or her condition or disease. Without commitment, without patient saying that, I am part of this whole process, we will not be able to be successful in managing the patient. Fourth, of course, is that we need to determine the patient's goals and respect those goals. And I'm sure you have heard many horror stories, no, of doctors who impose their own goals for the patient without giving the patient uh, due respect, or consideration. What are your goals for your own health? For instance, an elderly cancer patient with, you know, colon cancer, and the doctor will say you need to go undergo surgery or you need to go chemotherapy, without considering if at the stage of the life of the patient whether he or she would prefer to undergo surgery or chemotherapy that has its attendant risk, or simply live out the remaining number of months or weeks that she has with some form of quality of life issues. For example, that she can, you know, enjoy more time with his or her loved ones, spend more time with his or her loved ones, rather than go straight into surgery or chemotherapy, where she will be losing contact with her loved ones, or she might not even wake up, or she might be too debilitated to be able to do anything anymore. Like if you undergo chemotherapy and you are unable to function anymore, you're able to talk to your loved ones or spend time with them. So those are important considerations when we manage a patient. And lastly, of course, we should negotiate out respecting the patient's goals and objectives. Then you should negotiate a specific treatment plan and not impose your own decisions on the patients, because ultimately they are autonomous, no? And this is based on these following theories of social scientific uh, understanding of medicine. And when we look at the current development of medicine, we are no longer based on a pure biologic model of medicine where we just look at the body as a machine. We are now looking at the whole discipline of medicine as based on a biopsychosocial model of medicine, where individuals are actually not just composed of organs or tissues or cells, but they are also embedded within a relationship in the family, and this family is embedded in a relationship between other people within that community, and then this is within a larger society, and then wider environment, cultural environment, social environment, political environment, and this all play a role, no, in in the in the manifestation of our understanding of the patient's condition. So there's a lot of theory that are incorporated here. This includes your self-determination theory, shared decision making, especially with regards to managing the treatment of the patient, with regards to understanding what the patient really wants. We need to look at motivational interviewing, trying to surface the values of the patient. And of course, it's also based on social cognitive theory that our understanding of diseases is a shared a shared activity. It's not just expert driven. It is something that is determined also by culture, determined by the norms of society. And of course, today, because of the longevity of people's life, many people live with diseases because of medicine and medical technology. We are now able to lengthen the life of patients, even those who have diseases, so they live longer. So therefore, we need to take care of them in the chronic term, long term. So we have now a chronic care model. We manage the hypertension, we manage diabetes, and especially when you manage mental disorders, people with mental disorders, it will be based on a chronic care model. So this is the values that determine the framework of our mental health care model. One is we respect autonomy of the patient. They are not to be imposed upon. They determine their own fate, their choices. That is why we always seek consent for whatever we do to the patient. And we respect the patient as the expert in their own life experiences. They have their own needs, they have their own limits, and they have their priorities. And we will need to encourage self-management and self-efficacy, especially when you're dealing with chronic diseases. The doctor will no longer be the expert there, but we will need to depend really on the patient to take care of themselves and learn how to uh, best manage their own health problems. So this emphasizes negotiation rather than a prescribed approach to treatment, and therefore it is important to note, especially for managing patients with mental disorders, that you should have a patient-centered interaction when we are dealing with this kind of patients. So, but I think not only for mental health patients, but in general, when we look at all our patients that we encounter in the clinic, it is important that we will be centered on the needs of the patient. So patient-centered interaction. So this patient-centered interaction is four principles. One is educating the patient. Number two is obtaining commitment to the treatment plan. Then, of course, establishing what is the goal for treatment, and then negotiating your specific treatment plan. So in summary, this is our mental health care model. You have your patient-centered interaction. When you're looking at a particular patient, we need to educate the patient. We need to gain commitment of the patient to the treatment or to the understanding of what needs to be done. What are the goals that the patient wants to have? And based on this goal, we negotiate the treatment management plan. So it's no longer expert driven or doctor driven or healthcare professional driven, but it is centered on the patient's own needs uh, and understanding based on his own goals, based on his own situation. And I think with that framework, it will help us deal with a wide variety of clinical cases that we encounter during our work as doctors in the future. So I think that wraps up our session on the approaches to medical disorders, and we can slowly now go into the clinical categories of mental health disorders.